Welcome back to Griffonomics, where we conduct financial investigations to define the risk before we look at the reward. Today, we're diving into compass pathways, trading under the ticker CMPS.
And we are really looking at a pivotal moment. This isn't just another biotech story. This is a company trying to pull off a very high-stakes pivot from a pure clinical stage company to a pre-commercial leader in, well, a brand new field, really, interventional psychiatry.
The stakes feel immense on this one.
They are. Just, consider the sheer scale of the unmet need. We are talking about roughly 3 million patients in the U.S. alone.
3 million.
3 million who suffer from persistent treatment-resistant depression, or TRD.
And for that specific group, how well are the existing treatments actually working?
Poorly. I mean, tragically poorly. Right now, fewer than 5% of those 3 million people are being treated with a medicine that was specifically studied or even approved for TRD.
So they're just cycling through things that aren't designed for them.
Exactly. These are patients who've gone through multiple SSRIs, SNRIs, maybe even things like electroconvulsive therapy, and they've had little to no lasting success. I mean, they are the very definition of chronic need, and that treatment failure, that's what defines the commercial opportunity here.
That one statistic just frames the whole thing, the urgency and the market size. Okay, so let's clearly state our mission today. We're dissecting the entire investment thesis for CMPS.
Absolutely. And our central thesis today, I think, is really clear, and it defines the central conflict. Compass Pathways is executing this high-stakes pivot from a clinical biotech to a pre-commercial leader in interventional psychiatry. They're aiming to launch the first synthetic psilocybin therapy, CMP360, by late 2026.
There's always a but.
There is. Its ultimate success hinges entirely on converting I'd say, a palpable, favorable political tailwind into a successful and rapid rolling FDA submission. All while, and this is key, maintaining the critical long-term durability of its Phase 3 results.
So if that durability data, the data that's still to come, if that doesn't show a lasting effect,
the entire investment thesis just collapses. It doesn't matter how good the initial results are.
that sets the table perfectly. Okay, let's unpack this. We have to start with the science, because this is where the whole conversation shifted, and not just in the public, but inside the scientific community itself.
Right.
Let's talk about what the neuroscientist Dr. Andrew Huberman calls the scientific 180. He literally admitted his professional, deeply ingrained view on psychedelics completely flipped in just a couple of years.
He went from seeing them as dangerous drugs that could, ruin a career,
To now calling them compounds that could actually bend the arc of history in treating psychiatric illness. I mean, that is a massive endorsement from a very skeptical scientific community.
It's a profound shift, yeah. And it all stems from a deeper, but more rigorous understanding of the neurochemistry. For decades, these compounds were just lumped together as dangerous street drugs. Now we see them as highly specific pharmacological tools.
So what is psilocybin chemically?
It's a tryptamine, which, to put it simply, means its molecular structure is remarkably similar to our body's own natural brain neuromodulator, serotonin. That similarity, that's the core reason it can affect our mood and our cognition.
Okay, so if it mimics serotonin, and we already have this huge class of drugs that work on serotonin SSRIs, why haven't those already fixed the problem for these TRD patients? I mean, everyone knows someone on an SSRI.
And that gets right to the fundamental limitation of standard care. It perfectly highlights the difference between flooding a system and selectively targeting it. Serotonin is way more than just a happy chemical.
Right, it does everything.
Everything. It's all over the central nervous system, the gut. It regulates satiety, sleep, libido, memory, and, yes, mood. SSRIs just work by indiscriminately increasing the general availability of serotonin. They just keep it floating around, flooding the whole system.
And when you flood the entire system, you get noise.
You get noise, exactly. And that generalized noise is precisely what leads to the broad and often intolerable side effects you hear about. Things like emotional blunting, weight gain, sexual dysfunction. These drugs are just hitting every serotonin receptor in sight, the 5-HT1s, the 3s, the 7. They're trying to fix a specific mood problem by, well, imposing this massive systemic change that affects dozens of other functions.
So the SSRI is like flipping the main power breaker to an entire skyscraper.
Yeah.
Every single device on every floor gets power, whether it needs it or not. You might fix the flickering lights on the 50th floor, sure, but you've also created chaos. The cooling system is overheating, the shutters are going haywire, and the whole building is just buzzing with electrical noise.
That is an excellent way to visualize the lack of specificity.
Yeah.
Now, contrast that chaos with psilocybin's advantage, which is its extreme, almost surgical selectivity.
The master key.
Psilocybin is the master key. It specifically and maximally binds to one particular door, the serotonin 2A receptor, or 5-HT2A. This high affinity means that even though it looks like serotonin, its action is pretty much confined to just this one type of receptor.
And what happens when that master key specifically opens that one 5-HT2A door? Where are these doors and what's the immediate effect?
These 5-HT2A receptors, they're highly concentrated in very specific neural circuits, particularly in the prefrontal cortex, the part of your brain for, executive function, decision-making, and often those entrenched ruminating loops that are so characteristic of depression. When psilocybin maximizes its occupancy there, it triggers a whole cascade of events. But the most crucial one is profound neuroplasticity.
The actual physical rewiring of the brain.
The actual rewiring. This is mediated by things like the release of brain-derived neurotrophic factor, BDNF, which stimulates the growth of new dendritic spines. Literally, new connections are being formed.
So the goal isn't the trip itself. The goal is the physiological reorganization that happens because of it. The feeling is temporary, but the structural change is what actually treats the depression.
Precisely. The psilocybin experience might last 6 to 8 hours, but the therapeutic benefit comes from the lasting period of heightened plasticity that follows it. It's like you said, you're opening that one specific conference room in the skyscraper.
The 5-HT2A receptor in the prefrontal cortex.
To hold a critical therapeutic meeting where the brain can reorganize and literally bypass those old pathological depressive pathways, this selective mechanism avoids all that noise of a general serotonin flood.
Right.
That's the scientific reason why this is so revolutionary for patients who failed everything else. It's a single, powerful intervention aimed at structural change, not a daily pill for maintenance.
That analogy really does make the science stick, and it elevates the whole discussion from this is a Schedule I drug to this is an extremely selective neuroplasticity-inducing neuromodulator. Which brings us right to the clinical protocols, because this is clearly not a take a pill at home and call me in the morning kind of therapy. It's fundamentally different.
Not at all. It's an interventional treatment. It requires what Compass calls a highly controlled environment, delivered in licensed treatment centers. The patient goes through a long, supervised session, typically 6 to 8 hours, monitored by licensed healthcare professionals, often a team of 2.
And that setting isn't just for safety, right? It's part of the therapy itself.
It's integral to maximizing the therapeutic outcome, absolutely.
Okay, so let's get into the mechanics of that session. What parts of the Compass protocol are non-negotiable for making sure that rewiring actually happens?
2 elements are consistently cited and are absolutely core to the protocol. The use of eye masks and very carefully curated music. And this setup, it's far more than just creating ambience. It's a critical, deliberate clinical strategy.
Why the masks and the music? Is it just to make the patient comfortable?
No, it's to direct their attention inward. When a patient gets that high dose, the 25 milligram dose, they experience what's called escape velocity. They're taken beyond their everyday cognition.
Okay.
The eye masks and the music are designed to force the patient away from external, potentially distracting, or even negative hallucinations that could be induced by outside stimuli.
And instead, they're pushed towards, what, internal introspection.
Exactly. Emotional processing, accessing autobiographical memories. The benefit isn't just the drug. It's the internal psychological experience that's catalyzed by the drug-induced neuroplasticity. And that experience is then processed later with psychotherapy. So minimizing external distraction is paramount.
This sounds less like a drug model and more like a drug-assisted psychotherapy model.
That's the perfect way to frame it.
And that clinical promise is what really got the market's attention, especially for these patients with intractable depression, the people who failed 4, 5, 6 prior treatments.
Absolutely correct. I mean, if you look at the earlier Phase 2b data, which was the largest randomized controlled psilocybin trial ever completed at the time, the results were substantial. We saw statistically significant and clinically relevant reductions in depressive symptoms after just 1 dose at 6 weeks.
But the really eye-opening part was the durability, right?
That was the showstopper. Remind us of that metric.
A significant number of patients, we're talking about a full quarter of those on the active 25 milligram dose, were sustained free of depression all the way out to 12 weeks after 1 single administration.
Wow.
Not just improved, in sustained remission. For a population that is defined by chronic refractory illness where nothing else works, that initial response was nothing short of remarkable. It's what took this whole field from a research curiosity to a legitimate commercial biotech venture.
Yeah, you can see why. But given the history of these compounds, the Schedule I status, safety has always been the #1 concern for the public and for regulators. What does the current rigorous clinical data tell us about safety?
This is where we have to address the history, and where scientists like Dr. Huberman have been so important in correcting what he called bad science.
Right.
The negative perception that plagued this research for decades was often based on just flawed data. He specifically talks about the notorious retracted MDMA neurotoxicity myth.
Wait, I'm not familiar. Elaborate on that.
So it came from a very famous paper in Science magazine. Researchers were investigating MDMA, or ecstasy, but due to just a catastrophic lab error, they accidentally gave the subjects high doses of methamphetamine instead of MDMA.
Oh, no.
Yeah. And then they published these findings suggesting MDMA caused severe neurotoxicity. The error was eventually discovered, the paper was retracted, but the damage was done. That one finding was cited for years. It froze research and colored public and regulatory perception completely.
It's incredible how much damage a single error like that can do. So does Compass have a strategy to fight that kind of built-up negative perception beyond just showing the data?
Their strategy is the data. It's all focused on clinical rigor and transparency. And the current data, specifically from these large phase 3 trials using the clinically pure, standardized 25 milligram dose of synthetic CMP360, it indicates the safety profiles are, in his words, actually quite high.
When used in a controlled setting.
Right. In that controlled setting, the risks are highly manageable.
So what side effects do patients actually experience?
The observed side effects for CMP360 are generally very short-lived and non-serious. They're almost entirely confined to the day of dosing and maybe the next morning.
What are they?
The most common reports are headache and nausea, and critically, they pass by the second day at the absolute latest. They're temporary and predictable, which is a world away from the chronic, daily side effects of SSRIs.
And the Independent Safety Board, the DFMB, they've reviewed all this.
Yes. The Data Safety Monitoring Board has reviewed all the safety data from the ongoing phase 3 trials, and they've confirmed no unexpected or concerning safety signals have popped up.
And this is maybe the most important question for this specific population. What about suicidality?
Crucially, the DSMB found no imbalance in suicidality between the active treatment arms and the placebo arm. This is vital information for the FDA.
Why is that so important?
Because it strongly suggests that any instances of suicidal ideation or behavior seen during the trials are attributable to the underlying severe illness. This is treatment-resistant depression, which inherently carries a very high risk of suicide and not a side effect of the drug itself. That confirmation significantly de-risks the safety part of the whole thesis.
That's a strong segue into the phase 3 status, which is, where the whole investment debate has been centered recently. It's created enormous volatility.
I mean, the stock tumbled 50% after the CMP005 readout, yet management is out there saying, we're 2 for 2. We need to square that circle. Was this a genuine clinical failure, or was it a market perception problem?
This was overwhelmingly a market perception problem. It was driven by unrealistic expectations, not a failure in execution or meeting regulatory requirements. The company is, factually, 2 for 2 on statistically significant trials. The CMP005 trial absolutely met its primary endpoint.
How significant was the result?
Highly statistically significant, a p-value of less than 0.001. That means the result was not due to chance. The drug worked better than the placebo, period.
So if they hit the primary endpoint with flying colors, why the 50% stock tumble? I mean, that kind of reaction signals deep distress among investors. What did the market hate so much?
The market fixated on one thing and one thing only: the magnitude of the reduction. It creates a classic expectations gap.
Okay.
The primary endpoint was measured on the MADRS scale. That's the Montgomery-Åsberg Depression Rating Scale at 6 weeks. The CMP005 trial showed a note and a 3.6-point reduction in the MADRS score compared to the placebo arm.
And the previous phase 2b trial, that was a 94.2-point reduction. So the market punished them for a 0.6-point mathematical difference.
Exactly. The market had arguably just over-indexed on the extraordinary but small phase 2b dataset. Yeah. And they punished the stock for that fractional difference in a much larger, more robust phase 3 trial.
But management's take is what?
Management has been keen to reassure investors that, from a clinical perspective, a 3.6-point reduction and a 4.2-point reduction are highly comparable, especially when you factor in the natural variation in confidence intervals you always see in large clinical trials.
Let's ground that in reality. What is a clinically meaningful reduction on that scale? Does minus 3.6 points actually matter to a patient's life?
Yes, it matters significantly. While the scale goes up to 60, the generally accepted threshold for clinical significance, meaning the improvement is tangible and beneficial to the patient, is around a 3-point reduction over placebo.
So NATIS 3.6 clearly exceeds that.
Significantly exceeds it. And moreover, when you look at comparable approved treatments for TRD, like esketamine, their data often falls into very similar ranges.
Yeah.
The response was strong, it was statistically robust, and it was clinically meaningful. The sell-off was based on comparing phase 3 to phase 2, instead of comparing phase 3 to the standard of care or the regulatory bar.
That's an important distinction. It really shifts the discussion from market panic to clinical execution, and we should probably reinforce the safety confirmation here again. The DSMB looked at data from both phase 3 trials 005 and 006 and confirmed no imbalance in suicidality.
Right.
That's a huge de-risking factor that the market might have just overlooked in its panic over that tiny efficacy delta.
It's absolutely crucial. I mean, the DSMB confirmation gives them a much stronger foundation moving forward than they had after phase 2B. But now we move to the next set of massive gating items, the upcoming data releases that will truly determine the long-term viability and valuation. This is where the thesis is won or lost.
Let's nail down the timeline. What are the milestones that an investor needs to circle on the calendar for 2026?
Okay, the next major event is scheduled for Q1 2026. This is going to be a simultaneous release of 2 fundamentally crucial beta sets.
2 for the price of 1. What are we looking at?
First, we get the long-term 26-week durability data for CMPS-005. Now remember, that was the single-dose trial. This data will tell us how long that initial effect actually lasts. Does the patient stay in remission for 6 months?
And that is the make or break moment.
Absolutely.
If that effect fades quickly, say it only lasts 10 or 12 weeks, the whole commercial model is severely challenged, right? I mean, the cost and time of an 8-hour supervised session becomes really hard to justify if the patient has to come back every quarter.
Precisely. The duration of efficacy directly dictates the profitability of the commercial model and how acceptable it is to patients. If it lasts 6 months or more, that is a phenomenal value proposition. If it's less, the market will re-rate the stock dramatically lower.
And the second piece of data dropping in Q1 2026.
The second set is the 9-week data from the repeat dose trial, which is CMPS-006 Part A. This trial is designed to answer a really fundamental question,
Which is?
if the initial effect starts to wear off, can a second dose not only restore the therapeutic response, but maybe even increase it and sustain it without compromising safety? The 9-week data will give us our first look at the efficacy and safety of that retreatment strategy.
So Q1 2026 tells us pretty much everything about durability and the potential for a retreatment paradigm. What's the final hurdle before they can file the new drug application, the NDA?
The final gating item for the NDA submission is the complete 26-week data from that repeat dose CMPS-006 trial. We're currently guided to expect that full, comprehensive release in early Q3 2026.
Okay.
If both the 005 durability data and the 006 repeat dose data confirm long-term, sustained efficacy, either from one dose or the retreatment, the path is cleared for the regulatory filing.
Okay.
The market is essentially placing a 2-year bet on the success of those 2 readouts.
The scientific data is one leg of the stool, but the regulatory certainty is the other, especially with a Schedule A compound. Let's talk about the political environment. Are we seeing favorable tailwinds from Washington, or is this still a massive uphill political battle?
The climate has undergone a seismic shift in the last 5 years. It's moved from deep suspicion to creed interest. We're seeing significant political momentum that was almost unthinkable just a few years ago.
Really? At what level?
At the senior level, there's interest across the administration. You see commentary from influential political figures like former President Trump and RFK Jr., and you see attention from cabinet-level departments like HHS.
What's driving that top-level interest? How does that translate into actual action at the FDA?
The primary driver, really, is the crisis in veteran care.
Ah,
Exploring psychedelics for PTSD and depression in that highly vulnerable population is now widely considered a top priority for the FDA and for various government working groups. There's strong bipartisan public support behind cutting red tape to serve this group where current treatments are just failing.
so that creates an incentive for the FDA.
It does. It creates an environment where the FDA is incentivized to look very favorably upon rigorous clinical data. We've even heard commentary from people like Commissioner Marty Makary, who has publicly vowed to cut red tape in areas of high unmet need.
And does having that breakthrough therapy designation for TRD actually speed things up?
Okay.
Or is that just a marketing term?
Well, it's much more than marketing. It's a vital operational advantage. That designation is only granted when preliminary evidence indicates the drug might show substantial improvement over what's already available.
So it puts them on a different track.
It does. Because of that designation, the professional staff inside the FDA's psychiatry division has been highly engaged with Compass for 7 or 8 years already. It allows for regular, structured dialogue, a collaborative approach. It means the FDA is already familiar with the safety profile and the mechanism before the full application even lands on their desk.
So how is Compass trying to leverage that potential for speed in their submission strategy?
They're actively discussing a rolling submission strategy with the FDA, and this is key.
How does that work?
Well, typically a company has to wait until the final report is done, that Q3 2026 data, before they can submit the whole massive NDA package. A rolling submission lets them submit completed sections of the NDA-like preclinical data, manufacturing protocols, the CTIMP 005 data for a review as they finish them.
So the FDA gets a huge head start.
A huge head start. It could shave months off the total review time.
They also applied for that National Priority Review voucher, right? What is that exactly, and how much is it worth if they actually get one?
The Commissioner's National Priority Review voucher, or CMPV.
Yeah.
If they get one, that voucher can be used or sold to another company to grant a priority review, a faster timeline for any drug, for any indication.
And they're valuable.
Incredibly valuable. They often sell for $100 million or more. But management is realistic. They acknowledge that hundreds of companies apply, and the competition is fierce. So they're relying primarily on that positive, constructive dialogue with the FDA division rather than, counting on getting this voucher.
Which leads to their core philosophy, which I find really interesting in this politically charged field: no exceptionalism. Why is that stance so important?
It's a strategic de-risking position. By emphasizing no exceptionalism, they're stressing that while they appreciate the political tailwinds for psychedelics in general, they have to rely on rigorous, high-quality data and flawless execution.
Not political favors.
Not political favors or cutting corners. They're telling the investment community and the regulators, we will meet the highest bar required, period. It builds credibility and insulates them, at least somewhat, from shifts in the political winds.
But wait a minute. All the clinical rigor in the world can't change the ultimate reality, the DEA. FDA approval doesn't mean commercial launch, does it? This seems like the biggest non-clinical risk.
You have hit the nail on the head. This is the crucial, complex, non-clinical risk that analysts often struggle to model. Psilocybin is currently a Schedule I controlled substance.
Right.
Legally, that means it has no currently accepted medical use.
And the real-world consequence of that is?
FDA approval for COMP 360 is going to be contingent on the DEA, the Drug Enforcement Administration, rescheduling the drug to Schedule 234V. And crucially, commercial marketing can't start until that scheduling action happens after the FDA approval is granted.
Okay, walk me through that process. The FDA approves COMP 360. What happens next?
The process starts with the Department of Health and Human Services, HHS. The FDA formally requests a scheduling recommendation from HHS. HHS reviews the drug's abuse potential, its medical utility, its safety profile, and then they send that evaluation to the DEA.
So the DEA doesn't make the medical call, but they make the final logistical call.
Exactly. The DEA then takes the HHS recommendation and applies its own criteria to finalize the scheduling. And this is where political and administrative delays can creep in. If that process is delayed or it becomes politically complicated, it could significantly postpone the entire launch timeline, regardless of how good the clinical data is. The commercial clock doesn't start ticking until that final scheduling is confirmed.
What schedule are they likely targeting, and why does that matter commercially?
They're almost certainly targeting Schedule 3, and that's a key part of their model. Schedule 1 is no medical use. Schedule 2 is highly restrictive, think opioids, high-strength stimulants, with strict inventory controls, limited refills.
So Schedule 3 is the sweet spot.
Schedule 3, like ketamine, has a lower potential for abuse. For Compass, getting Schedule 3 status is crucial because it allows for much more efficient distribution and prescribing practices. It just makes it easier for treatment centers to manage inventory and for patients to get retreatment.
Is there a precedent for this?
There is. The DEA has a historical precedence for quickly rescheduling things after FDA approval. But given the public profile of psilocybin, this step remains a critical point of uncertainty.
Which brings us to the final verdict, the commercial reality. Let's assume the 2026 data is strong, the regulatory path is navigable. How do they actually plan to commercialize a therapy that requires 6 to 8 hours of supervised attention? That infrastructure challenge is massive.
It is the single largest commercial hurdle, but this is where their strategy really shines because they are not starting from scratch. Management's plan is to commercialize COMP 360 alone in the U.S., and their entire strategy is built around leveraging existing approved infrastructure that was built by their competitors.
Okay, let's use the analogy here. Compass is moving into an existing apartment complex of interventional psychiatry infrastructure. What does that complex look like today? Who built it?
That complex is the ecosystem built largely by Johnson & Johnson over the last 5 years for their TRD treatment, esketamine nasal spray, which is marketed as Spravato. There are approximately 6,000, maybe more, Spravato treatment centers in the U.S. that are already operational and certified.
And why is that so crucial for Compass?
Because these sites are already perfectly capable of doing this. They have the dedicated, comfortable rooms, they have the operational know-how for scheduling and team-based care, and they already understand payer reimbursement for these kinds of novel supervised therapies.
That's important.
And most importantly, they already have the knowledge and infrastructure for handling REMS programs, risk evaluation and mitigation strategy programs, which CMP 360 is absolutely certain to require.
Let's pull on that thread, the REMS program.
Hmm.
That's often overlooked. It's required for drugs with serious safety concerns. What does managing a REMS program actually mean for a clinic?
It means massive administrative overhead and strict security, which is why using this Spravato infrastructure is so powerful. For a drug like CMP 360, a REMS program will likely mandate specialized certification for every center, a patient registry to monitor outcomes, mandatory patient follow-up, and very specific secure drug handling protocols. The Spravato centers are already accustomed to this high level of operational rigor.
So CMP 360 is the prefabricated appliance, the synthetic drug that fits right into the existing electrical outlets, which is the regulatory and payment framework.
Exactly. And the payment infrastructure is the critical piece that de-risks provider adoption. Specific CPT-3 codes. These are temporary codes for emerging tech. They were made effective in January 2024 for psychedelic drug monitoring services.
Why is the existence of those codes so important?
This is fundamental to commercial success. These codes allow the clinics, the providers, to bill for that mandatory high-overhead hourly monitoring through the medical benefit. This is separate from the cost of the drug itself.
So it ensures the providers get paid for their time.
It ensures they're paid for their time and their high overhead, regardless of how long the session is. It essentially takes the financial risk away from the physician, which encourages them to adopt the new therapy. They don't have to force their Spravato patients to switch. They can just use their existing setup to service a new, highly refractory group of patients.
Let's talk financials. Do they have the runway to get through this final, critical 26-month journey of readouts and submission? A high-stakes pivot like this needs serious cash.
The financial health looks solid, which reduces the immediate risk of dilution. As of their last filing, for the period ending September 30, 2025, they reported robust liquidity, $185.9 million in cash and cash equivalents.
What's their burn rate like?
It's significant, around $35 million in net cash used for operations in the third quarter of 2025. But based on current projections, they expect this existing capital to fund operations comfortably into 2027.
So that gets them past the finish line.
It gives them enough capital to reach both of the final Phase 3 readouts in 2026 and the expected NDA submission date without needing to do an emergency fundraising.
And what about the IP, the intellectual property protection? Psilocybin is a natural compound. How do they protect their product from generics?
This is a major defensive asset, and it's why they went with the synthetic approach. COMP 360 is a fully synthetic, proprietary crystalline form of psilocybin, and that synthetic formulation provides strong composition of matter and method of use IP protection all the way through 2038 with potential for extensions.
And that long patent life is essential.
Absolutely essential for a product that requires this much of a commercial build-out. It protects our first-mover advantage.
Okay, so let's synthesize everything. We have promising, highly specific science. We have a 2-for-2 Phase 3 track record despite the market panic. We have political tailwinds, existing commercial infrastructure, and a healthy cash runway. What is the central, unavoidable investment risk right now? Where is this thesis most fragile?
It boils down entirely to the successful alignment of those two factors we set up at the very beginning, both of them anchored firmly in the year 2026. The investment hinges on them hitting these two targets.
Number one.
First, the durability data. The single-dose 26-week data in Q1 and the repeat-dose 26-week data in Q3 must confirm that the long-term sustained efficacy goes way beyond that initial 6-week result.
Because if patients need retreatment too often,
If they need it more often than, say, once every 6 months, the economics of this whole interventional therapy model just break down, and the value proposition versus a daily pill disappears.
and the second point of fragility.
Second is their ability to smoothly navigate the complex and potentially delaying process of DEA regulatory scheduling after the FDA approves it. The political climate is favorable, yes, but administration and legislative action can be slow. If the FDA says yes in late 2026, but the DEA process stalls,
Or gets stuck in politics.
the market opportunity just freezes for months, maybe longer, regardless of how good the clinical data is. Those are the two critical axes of risk.
Okay, here's where it gets really interesting for me, looking beyond that core TRD risk. If this initial CMP360 strategy succeeds, what is the long-term runway for this technology? How big is the vision beyond chronic depression?
The runway is immense, and they're already executing on the next move, which shows foresight. The company is in the final stages of designing a late-stage clinical program for PTSD.
Post-traumatic stress disorder, that is a massive population.
It is. We are talking about a patient population of around 13 million people in the U.S. alone who suffer from chronic PTSD. And the crucial point here, just like with TRD, is the woeful inadequacy of the current treatments.
What's available now?
The only 2 approved pharmaceutical treatments for PTSD were greenlit in the last century. There's been almost zero innovation. If CMP360 can successfully translate its efficacy and that neuroplasticity mechanism from depression to PTSD, it signals the potential for a broad, multi-indication pipeline that could transform a huge portion of interventional psychiatry.
Potentially going into anxiety addiction.
Anxiety disorders, addiction, chronic pain down the line. That pipeline expansion is the long-term multiplier for the stock, but only if the core TRD strategy succeeds first. And that's something for you, the listener, to really consider as these critical Q1 and Q3 2026 data drops get closer.
We'll be watching those Q1 and Q3 2026 data releases very closely to see if that durability holds and if the commercial model is validated. Risk defined. Portfolio protected.